Let's talk about the vasa recta. Now we want to understand here, we've been talking about the movement of fluid from the tubule into the blood vessel. We want to bear in mind that it's moving from the filtrate is moving from the tubular structure, from the descending limb into the vasa recta, that network of capillaries around the loop of Henle. And so when you look at take this image, when you look at the vasa recta here, so this is a transposed or an inverse image. So we're not looking at the tubule here. What we're looking at is the vasa recta, the movement of fluid into the vasa recta. Okay? And so what we'll see is that the vasa recta prevent the diffusion of water to sort of dissipate that gradient that we worked so hard to set up. It's not going to just allow water to just wash down that gradient. Again, this gradient is important in facilitating the movement. And we need this movement. And so what happens in the descending limb, again, of the vasa recta, not of the tubule here, we have an osmolarity of about 300 milliosmoles. And as this descends, water is moving out of the capillary, and it's going to move into the interstitial tissues here. Okay? We also have the movement of water. So water is coming from the tubule into the vasa recta. Okay? And so what we have is an opposite gradient from what we saw in the tubule, in the tubular structures. Similarly with the ascending limb. Ascending limb of the vasa recta. So you want to picture in your mind that the descending limb of the vasa recta is at the same area with the ascending limb of the tubule, and vice versa. Okay? And so we have the movement of water in the ascending limb into the plasma. We also have the reabsorption of those solutes into the interstitial fluid around the area. Remember that salty medulla that I talked about, those solutes being reabsorbed, making that medulla very salty? This is where we can see that happening. All right, so we have a high osmolarity here, which again facilitates that countercurrent movement. We make the medulla salty, water is reabsorbed on the other side. Any questions on this area or these topics? The countercurrent mechanism. Any questions on the movement? Oh, we're almost out of time. Any questions so far? Okay, try to practice sort of going over these. I put lots of images, try to look at the images, draw, label, and just practice with these concepts. The next concept we'll talk about is the reabsorption with the help of hormones, right? That regulated reabsorption. So just to give a nice big breakdown of the water reabsorption across the kidney, most of it happens in the proximal tubule. Again, we said about 70 to 80%. And this was not regulated. The remainder of it happens in the distal convoluted tubule and the collecting ducts, and this is regulated. Okay? And it's regulated with the presence of the hormone ADH. Does anyone remember ADH? I think Dr. Schrader would have talked about that in the endocrine system, ADH. You remember what it is? What does it stand for? Anti-diuretic hormone. So what does that mean? When I'm thinking about ADH, what's happening? Anti-diuresis. Diuresis meaning what? Peeing. So ADH you should be equating with not peeing or holding on to water or anti-diuresis. And we'll talk about how that hormone regulates the reabsorption of water based upon your hydration state. So depending on your hydration status, whether you're well hydrated or not so well hydrated, the distal collecting duct, in the distal convoluted tubule will represent certain channels, which we call aquaporins. And these aquaporins are going to be inserted into the membrane of the tubule, and water will flow through these channels. Now, the presence or absence of these channels is directly related to the ADH hormone. So if you have lots of ADH, right, you're thinking holding on to urine, anti-diuresis, are you going to put more or less aquaporins into the membrane of the tubule? You want to hold on to more water. You want to put more channels into the membrane, or you want to put less channels? Hmm?
You want to put less.
Do you? Think about it.
Hold on to the water.
You want to hold on to water.
If you had more water flow through.
So water's going to flow through, but that's what you want because you want it to go from the tubule back into your body. So remember we're talking about tubule to blood vessel. And so the more channels you have in the membrane, the more water you'll sort of suck up from that tubule and prevent it from being excreted, prevent it from being peed out as such, okay? And so you need to make that connection here. ADH, where's ADH released and stored, by the way? Or made and stored? ADH, come on. Pituitary, what part of the pituitary? Posterior, right? So the posterior pituitary is responsible for the storage and release of ADH. And we say the storage and release because, strictly speaking, those hormones are made in the hypothalamus. And those long axons go from the hypothalamus right to the infundibulum, down into the posterior pituitary where those hormones can be released, stored, and then secreted as needed. Okay? And so what we see here is that depending on your hydration status, you either secrete more ADH or you don't. Right? You either secrete more ADH or you don't. What part of the tubules is this affecting again? I keep driving this point home. What part of the tubules is this affecting? What part of the tubules is regulated? The distal convoluted tubule and the collecting duct. Good. So water cannot leave the tubules if you don't have aquaporin channels. No water will be absorbed. More water will be lost or excreted in the urine. Let's say we are dehydrated. Let's say we're severely dehydrated. Our body decides to secrete more ADH and say, look, let's hold on to some more water. The secretion of that ADH stimulates the insertion of aquaporin channels, specifically aquaporin 2, into the membrane and we absorb some water. Now on this side, I forgot to distinguish between those two different types of aquaporins. So there's aquaporin 3, which is on the basolateral membrane, right? Again, more closely associated with the blood vessel, versus aquaporin 2, which is on the apical side of the membrane. And this is the one that's regulated. Aquaporin 3 is not regulated. Only aquaporin 2 is dependent on the presence or absence of ADH in the blood. Okay, so we need to make that distinction very clear. So aquaporin 3 really has no value for us, so to speak. What we're really interested in is aquaporin 2. This is the one that's highly regulated based upon ADH. All right. We'll touch a little bit again on that obligatory water loss. Anyone remember what that was? Talked about it earlier on. Obligatory. Right, so that's the minimum that you must excrete in terms of volume each day. So you must pee about 400 milliliters of fluid every day. There are some important solutes that must be excreted, and they must be excreted, let's put it simply, they must be excreted in fluid. You can't just excrete salt, okay? So in order to lose those waste products, in order to lose those solutes, there is a minimum of at least 400 to 440, there's some discrepancy there, milliliters per day, okay? So if you see a patient that's not peeing at all, there's some severe kidney problems, okay? I'll probably, let's see, what do we have left to talk about? Okay, so let's keep going here. So we talked about ADH, we talked about its ability to regulate which aquaporin?
2.
Aquaporin 2, into what areas of the tubule?
Collecting ducts.
And
GCT.
GCT, correct. And what was the general function of ADH in terms of hydration status?
Activated aquaporin 2.
Activating aquaporin 2 by preventing water loss, right? Preventing excess water loss in the urine. Okay. Now the urine osmolarity should be anywhere between 100 to 1400 milliosmoles. And that basically means how concentrated is your urine, again, how salty is your urine, how much solutes are in your urine versus how much water. And so if you have a very concentrated urine of about 1400 milliosmoles, I don't think it can be any more salty, any more concentrated than that. This means that you are not reabsorbing any water at all, very little water. All you're absorbing is that, what was that figure? What do we call that figure? All that you're losing is what? That obligatory minimum, right? That obligatory water loss. So all you're losing is about 400, because you have a very salty urine, right? That gives you urine osmolality about 1,400 milliosmoles. The other end of that spectrum is if you have very watery urine, and if you're peeing a lot, this can be brought about by different hydration states, different disease states, et cetera, Brain injury can cause this. If you're not releasing ADH, but you'll have very watery urine, and the osmolality would be significantly less. All right, let's talk here about the exact mechanism. We don't have much time. Let's see what we can get done. Let's talk about the exact mechanisms of that ADH and those aquaporin channels. So again, we have ADH in the blood. This is a hormone coming from the posterior pituitary, circulating in the blood, and it's going to be released in response to, again, your hydration status. If you're well hydrated versus if you're not so well hydrated. So if you're dehydrated, that's where this kicks in. You're severely dehydrated, that's where your pituitary says, okay, look, I'm going to secrete some ADH. That circulates into the blood, makes its way down into the kidneys, and it goes from the blood, just diffuses right across the peritubular fluid, and it's going to bind to this ADH receptor. All right? And so it's binding to this receptor, and that's going to stimulate or start this whole cascade of events. We talked about this signaling cascade, where one second messenger molecule turns on another second messenger molecule, et cetera, et cetera, et cetera. We have tons of phosphorylation or dephosphorylation depending on the proteins, and then we generate some sort of end response. And in this case, that end response is to make aquaporin. What type of aquaporin? Aquaporin 2. Okay, so this is the mechanism by which the ADH from the blood binds to this receptor, turns on a G protein. That G protein dissociates. We talked about this cascade last semester, and we have basically the insertion of these aquaporins onto the membrane. Now, the insertion of these aquaporins means more water is reabsorbed. Okay? All right, some of the factors that affect the secretion of ADH, one we mentioned was the blood that's circulating in the posterior pituitary. Right? We also have the baroreceptors. So baroreceptors throughout your body are basically detecting blood volume, blood pressure, how perfused your body is. And if you know, if it realizes or senses that blood volume is low, it's going to trigger the release of that ADH secretion. Ready? So we talked about two mechanisms. One is going to be the flow of blood in the pituitary. Two is going to be the baroreceptor activity. All right. And this flow chart sort of is an example of how that is brought about. So let's say you have osmolality increase in your extracellular fluid, meaning that it's really salty, meaning that you're dehydrated. The signal is for the hypothalamus to detect that change. It's going to stimulate the release of ADH from the posterior pituitary, and then that release of ADH goes down to the kidney, facilitates the insertion of more aquaporins. Aquaporins will then allow flow of water from where to where? Aquaporins are allowing the flow of water from where to where?
In the collector ducts and then DCT to the blood.
Perfect. So from the collecting duct and the DCT back into the blood circulation, right? We're trying to keep that water. And then when that is fixed, when that is resolved, what do? We turn back off that signal. So this is a negative feedback loop. When that initial stimulus has been resolved, we have our osmolality back to about 300 milliosmoles. We can shut off that system. We can shut off that ADH. We can stop inserting aquaporins into the membrane. Okay, very similar here with the baroreceptor example, same phenomenon. Baroreceptors detect that change, stimulate the secretion of ADH, et cetera, et cetera, et cetera. That signal is turned off once the mean arterial pressure rises, once the blood volume rises. Okay. The last thing we'll touch on here is the regulating of GFR using this mechanism, something we talked a little bit about before. So we mentioned that there's that range between which GFR does what? Between 80 and 180, what's the GFR? Stable. What's the number? What's the GFR? About 125, right? So if you remember that graph, between 80 milligrams of mercury and 180 milligrams of mercury, again, that's the mean arterial pressure. Between that mean arterial pressure, we don't have any fluctuation in GFR. This is where the regulation comes in. It's auto-regulated. What are the three mechanisms? Talked about them. Beginning of this class. So that tubular glomerular feedback, right? The juxtaglomerular cells, which are bringing about the myogenic response, and then the mesangial cells, right? Don't forget those three mechanisms. So those are the mechanisms by which the kidney intrinsically regulates the GFR. Outside of that 180 to 80, the kidneys can do nothing. GFR is going to suffer if you have a mean arterial pressure less than 80. Your kidneys will shut down. It's inevitable, right? Water excretion will decrease. Filtration will decrease. Similarly, above 180, right, high pressures, GFR will increase. It will not stay stable. Water filtered will increase. The amount of urine you lose will increase. Okay, so you want to bear this window in mind. And again, the window is representing the mean arterial pressure here. All right, any questions?